Potassium sparing diuretics include two types of drugs, aldosterone antagonists and sodium channel blockers. They are named according to their mechanism of action. They have the same net effect but they act differently. Aldosterone antagonists, as the name indicates, they will antagonize the hormone aldosterone, and sodium channel blockers, they will cause blockage of the sodium channels. So they will act differently. Aldosterone antagonists include two drugs which are spironolactone and eplerenone. And just keep in mind that both these are steroids. They are synthetic steroids. Spironolactone is a prototype, whereas eplerenone is a recently developed drug. Now, an important point to remember regarding spironolactone that it is not specific for the aldosterone receptors and it will affect other target organs, other endocrine organs also. So, spironolactone and eplerenone, these are aldosterone antagonists, and sodium channel blockers include Triamterene and Amiloride. So, these were the drugs which are grouped under potassium sparing diuretics. Now we see their pharmacokinetic profile, and first is the route. So, they are available by oral route as tablets. Once you take them, where will they go? They will act in the kidneys, in the collecting tubules. Then how long will they act? This is different for the individual drug. For Triamterene, the duration of action ranges from 14 hours. For Amiloride, it is 24 hours. For spironolactone, it is 60 hours. And for eplerenone, it is 72 hours. So, to make it easy, you can say that duration ranges from 14 to 72 hours, and it is different for the individual drugs. Spironolactone and eplerenone, they are longer acting, whereas Triamterene and Amiloride are having shorter duration of action. So once they have finished their action, next is the excretion, and they will be excreted by the kidney. So this was the pharmacokinetic profile. Now we will see the mechanism of action, and this is the most important part. Just look here, this is a principal cell and intercalated cell of the collecting tubules. On one side there is lumen, on the other side there is interstitium. Now on the luminal side of the cell there are epithelial sodium channels which will cause sodium reabsorption into the cells, and again on the luminal side there are potassium channels which will cause potassium secretion into the lumen. On the basal side there is sodium potassium ATPase. Now first of all we will see what is the normal mechanism. We know that aldosterone is a mineralocorticoid hormone. What will it do? It will combine with the intracellular receptor. It will form a complex, and this complex will cause synthesis of proteins which are known as aldosterone induced proteins, and these are sodium channels and the sodium potassium ATPase. So basically aldosterone through the synthesis of proteins is going to mediate the sodium reabsorption, and it is also going to indirectly cause potassium secretion into the lumen. Next, in the intercalated cell, you can see that on the luminal side there is a proton pump, and on the basal side there is a chloride bicarbonate exchanger. So, hydrogen secretion is also occurring in this part of kidney. So, what happens? When the aldosterone is blocked by the aldosterone antagonist, this sodium reabsorption, potassium secretion and hydrogen secretion will be blocked. And you can easily see that aldosterone antagonists, they will act on the aldosterone hormone and they will block its effect. Whereas sodium channel blockers, they have nothing to do with the hormone aldosterone. Rather, they will directly block the epithelial sodium channel. So the net effect is same, that they are going to decrease sodium reabsorption, they are going to decrease potassium and hydrogen secretion, but they are acting at different sides of the same part of the kidney, that is collecting tubules. So this was the mechanism of action. Now we will see the dosage, and again the dosage is different for each individual drug. For amiloride, it is 5 to 20 mg per day. For eplerenone, it is up to 50 mg per day. For triamterene, it is up to 300 mg per day. And for spironolactone, it is even greater, up to 400 mg per day. So the dose is different for each individual drug, and the dose is tailored according to the symptoms and the needs of the individual patients. This was the dosage. Now let's see the therapeutic uses, and the first and most important is fluid retention. Whenever there is pull up of excess fluid in the body, whether it is due to heart failure or it is due to hepatic failure as in ascites or it is due to nephrotic syndrome, the potassium sparing diuretics, particularly the aldosterone antagonists, they are beneficial. Why? Because all these conditions, they ultimately lead to rise in the aldosterone levels. So aldosterone antagonists, they will help to relieve the symptoms of such patients who are having fluid retention. Next is hypertension. Regarding hypertension, you should keep in mind that they are weaker diuretics. Alone they are of no benefit, but they can be used to achieve a better and a good control of blood pressure if you are using them in combination with other drugs, in combination with loop diuretics or thiazides. Next is hypokalemia. As we have seen that the major drawback with other group of diuretics was potassium wasting. So to overcome that, we can give potassium sparing diuretics to the patients. Next is PCOS and hirsutism, and this is an interesting use, and you should remember that this use is particular for spironolactone only. Spironolactone, it is a steroid, but it is very non-selective. It does not affect only the aldosterone, rather it affects other endocrine organs, other endocrine receptors. So this property of spironolactone makes it useful for management of polycystic ovaries and hirsutism patients. So anti-androgenic effect of spironolactone is beneficial for PCOS and hirsutism patients. Again, hyperaldosteronism, when there is excess of the aldosterone in the body, whether it is due to some tumor of the adrenal gland or there is some ectopic source. So spironolactone, which is an aldosterone antagonist, is again useful for its purpose. Fluid retention, hypertension, hypokalemia, PCOS hirsutism and hyperaldosteronism, these are the therapeutic uses of potassium sparing diuretics, and you should keep in mind that the endocrine effects and the endocrine uses are only for spironolactone, not for the other drugs. Now we will see the adverse effects, and the first and most important is hyperkalemia. So whenever you are going to prescribe potassium sparing diuretics, we have to keep an eye on the potassium levels. We have to monitor the potassium levels because they are causing potassium retention in the body. So it can lead to hyperkalemia that can be life threatening. So always monitor potassium levels. Next is gynecomastia and impotence. So as I have told you before that spironolactone is having effect on other endocrine organs, and it is the major drawback that it will affect the other target organs, and this can lead to undesirable effects like abnormal enlargement of mammary glands in males, impotence, menstrual irregularities in females. So these are particularly the adverse effects pertaining to spironolactone, and they are because it is non-selective, non-specific antagonist of the receptor aldosterone. Next is GI distress. All the potassium sparing diuretics, they will cause GI distress and they can lead to peptic ulcer and GERD symptoms. So always prescribe some antacids, some PPIs whenever you are going to give potassium sparing diuretics to the patients. Next are the renal stones, and this is important for the triamterene. Remember from the MCQ's point of view, that triamterene is relatively insoluble and it can precipitate in the kidneys and it can lead to stones. So never prescribe triamterene to a patient who is already having the renal stones. And lastly are the hematologic disturbances, and these are again confined to triamterene and amiloride. Rarely they can cause blood dyscrasias and other blood cell abnormalities. So most important, hyperkalemia, then belonging to spironolactone are the endocrine effects, which are gynecomastia, impotence, menstrual irregularities, GI distress, renal stones, and hematologic, particularly for the triamterene and amiloride. These were the adverse effects. Now we will see the contraindications, that in what conditions you should never ever prescribe potassium sparing diuretics. And the first is renal insufficiency, because the patients who are having acute renal failure or who are having deranged RFTs, they are at risk of developing life-threatening hyperkalemia if they are given potassium-sparing diuretics. So never give potassium-sparing diuretics to the patients who are having renal impairment. Next is hyperkalemia, that if the patient is already having disturbances of the electrolytes or he is having elevated potassium levels, so never ever prescribe potassium sparing diuretics, because it can be devastating for the patient. And last is hypersensitivity, that if someone has reported hypersensitivity to this group of drugs, he should not be given them for any purpose. So renal insufficiency, hyperkalemia and hypersensitivity, these are the contraindications. Now let us see the interactions. You can easily remember the drug interactions by the mnemonic LACT. Just remember this mnemonic and you will never going to forget the drug interactions of potassium sparing diuretic. First is lithium. So never ever give lithium and potassium sparing diuretics together. Next are ACE inhibitors. Both ACE inhibitors and angiotensin receptor blockers, they cause hyperkalemia, and potassium sparing diuretics also elevate the potassium levels, so they should not be given together. Next is cyclosporine, and again there are potassium supplements. So if the patient is having potassium supplements, potassium containing diet or potassium containing medicine, he should not be given this group of drugs. So never give them to the patients who are having supplements containing potassium. Next is digoxin, because these drugs, they will cause the serum levels of digoxin to rise. So digoxin and the potassium sparing diuretics, they should not be given together. So lithium, ACE inhibitors, cyclosporine, potassium supplements and digoxin. Never ever prescribe these drugs together, because they have serious interactions and that can be life-threatening for the patient. So this was all about potassium sparing diuretics. Hope you find this video useful and stay tuned to sqadia.com for more.